Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for the third episode of Emerging Strategies to Address Management Challenges in Dyslipidemia. I'm Dr. Deepak Bhatt, joined today by Dr. Scott Wright. In this final episode, we will be discussing a case presentation, consequences of poor medication adherence, patient engagement and education, improving collaboration and interprofessional care, and lastly, tools and resources to support primary care clinicians. So let's quickly go through a case here. This is a 64-year-old male, a non-smoker, has hypertension and diabetes, along with proteinuria and retinopathy, as well as mixed dyslipidemia. He's currently on metformin and metoprolol, simvastatin, and aspirin. The weight is 97 kilograms, a BMI of 28, so that means overweight, blood pressure of 140/90, elevated heart rate of 82, no murmurs, and the lipid profile shown here. The LDL is 175 milligrams per deciliter, HDL is 40, triglycerides are 200. So not a great lipid profile. And the hemoglobin A1C is 8%, also not ideal. So here are the various different risk categories where we want to consider what LDL threshold we should go to in this patient. And again, just to recap some of the different things in their history, you see our hypertension, bad diabetes, and mixed dyslipidemia. So if we're starting with an LDL cholesterol of 175, if we go ahead with moderate intensity statins, well, then that gets us to 123-ish or so. If we add ezetimibe, that would get us to 96. If we go with high-intensity statins right out of the gate, that gets us to 85, and with ezetimibe, that would get us to 61. But if we went with a PCSK9 inhibitor type approach plus a high-intensity statin, that gets us to 35. So if our target LDL here, we say, is a 50% reduction in less than 55 milligrams per deciliter in this extremely high-risk patient, well, then that combo therapy with the PCSK9 inhibitor and high-intensity statin looks like it would do the trick. So there are lots of different considerations in lipid-lowering therapy, but high-intensity statins, you can get about a 50% LDL reduction. With PCSK9 inhibitors, also a 50% LDL reduction, even if they're already on statins. That's true of the siRNAs. The monoclonal antibodies may be a little bit higher in terms of the LDL reduction, around 60-ish%, whereas with moderate intensity statins, about 30-ish%, with the selective cholesterol absorption inhibitors, about 20-ish%, and the ACL inhibitors, that's the adenosine triphosphate citrate lyase inhibitors, around a 15-ish% reduction in LDL. And this idea of combo therapies is very popular in hypertension. In fact, many guidelines recommend combination therapy as the initial therapy in hypertension. Some of us that may have gone to medical school years ago were always taught to start one agent, max it out, and move on to the second one. But the most current thinking data and guidelines really support lower doses of combo therapy to minimize side effects and maximize adherence. And I think in dyslipidemia, we are also gradually moving in that same direction. As far as mechanisms of action of lipid-lowering therapy, Dr. Wright has already done a great job with this, so for the sake of time, I'm not going to go through every step here other than say there are many different drugs, many different pathways, and we should utilize this science to try to get our patients' LDL cholesterol as low as possible without inducing side effects. So getting back to this patient, some possibilities include changing the simvastatin to atorvastatin or rosuvastatin at a maximally tolerated dose, adding ezetimibe, adding a monoclonal antibody, PCSK9 inhibitor, adding inclisiran, or adding bempedoic acid. And one could potentially make an argument for any or some combination of these. Maybe I'll just pause for a quick second here to ask Dr. Wright what he might do in this particular case.
Thank you very much. I tend to want my patients to see success as quickly as possible. I think coming back from multiple lipid checks every 2 to 3 months with the cost of blood work, the cost of being off work, or the transportation hassles for families who bring a retired parent with them, is such that I like to go, I do a calculation to say, where do I want the LDL to be? And if I think it's going to have to drop like the patient we have to escalate right up, I think stepping through multiple changes and multiple dose iterations just leaves everyone feeling a little frustrated at the patient end, and it's costly to them when we can just get there more quickly with the combination therapy. That's what I would do.
Yeah, no, that makes a lot of sense. All right, so now just in the final few minutes, let me just go through some of the consequences of poor medication adherence. And this sort of summarizes things. As adherence goes down, the risk goes up. And that's a real challenge in our complex patients. These are some data from the SECURE trial. This was a trial of post-MI patients, usual care versus a polypill. And the polypill strategy showed a significant reduction in ischemic events, including a significant reduction in cardiovascular death. And I'm not showing this to say to use a polypill if one were available. It certainly could be a possibility. But rather, when we look to see what was the mechanism of benefit, it really was greater adherence with the polypill versus just taking a bunch of individual medicines. So the point here really is that better adherence can improve the rates of ischemic outcomes, including cardiovascular death. So in terms of adherence, medication burden has a big part of it. Statins, we all know adherence isn't so great, maybe 50% or so at a year of patients post-MI are still on their statin. Now, with the monoclonal antibodies, the adherence does get better with the every 6-month injections, with the siRNAs, even better yet. In theory, in the future, if such therapies are found to be effective, vaccination might be useful in terms of vaccinating against LDL. And then gene editing could potentially be a once-in-a-lifetime approach. The first human data has been presented, but we need to have more patients and longer-term follow-up. But certainly opens the door for 100% adherence in those that do actually undergo gene editing. I'm going to mention the Samson trial and the nocebo effect. And basically what that showed was that 90% of adverse symptoms related to statins were also elicited by a placebo. And that's what we mean by the nocebo effect, where patients have been surfing the internet, and they've read about statins, they've read about all these side effects, and then they start having them, even though they would also have them if they're getting a placebo, but told the placebo is a statin. So what this means is we can sometimes educate a proportion of those patients, maybe half those patients, to actually take their statins. The other half are going to keep just having symptoms, and there are alternative therapies of the sort we've discussed can be useful, things like bempedoic acid, the PCSK9 inhibitors, etc. Just a quick word about patient-centered education. This is important. This needs to be multi-pronged. We haven't said so much about it, but lifestyle intervention, dietary education, all very important. Exercise as well. Cardiac rehabilitation in appropriate candidates can also be useful for that purpose. As far as methods to improve collaboration and interprofessional care, certainly shared decision-making can be an important part of that. Working with our patients to reach decisions as far as the best therapies for them, not just factoring only the data and the guidelines, but also side effects and tolerance for different sorts of dosing intervals, dosing modalities, injection versus pill, etc. Need to factor all that in. And here's one approach of shared decision-making using the SHARE approach, that is seeking your patient's participation, help your patient explore and compare treatment options, assessing their preferences and values, and then reaching a decision with the patient and evaluating the patient's decision. So with that, let me turn things back to Dr. Wright for a quick wrap-up here before we close.
Yeah, thank you, Dr. Bhatt. Let's talk a little bit about tools and resources. We'd like your opinion about which tools and resources you find most beneficial for supporting your practice. Would it be A, online decision aids, B, guideline statements, C, clinical experience alone, or D, peer-reviewed journals? I know most of you would like to pick more than one, but we will just need to have you pick one. Dr. Bhatt and I have both served on guideline committees together, and they have their place, of course, but they're not the only option that we have. Oh, wonderful. I understand a majority of you like the guideline statements. Well, Dr. Bhatt and I both appreciate that. There is a tremendous amount of work that goes into those. But I do think, as you will see here, online decision aids are helpful. Peer-reviewed journals are extraordinarily helpful because guidelines lag peer-reviewed journals by 2 to 3 years. And then never underestimate or sell short your own clinical experience. So here are some, thoughts about things you can do. I'm not going to spend much time on this. Many of these decision aids are available on the web from this education provider as well as others. And let me just say in summary and in conclusion that we appreciate your time tonight, your participation with us. We hope that we have shared with you that it's very important to aggressively lower LDL cholesterol and to take it to extremely low levels if we're going to truly mitigate the risks that our high risk and very high risk patients have. That focusing on LDL reduction is the key now. It's not HDL, it's not total cholesterol, it's not a ratio, it's really LDL, because LDL contains all, most of the ApoB containing lipoprotein is LDL. And it's important to know which threshold to go for, whether it's 50 or 55, 70 or 100. Calculate how much LDL reduction you need, maybe as a percent, and then start the therapies to deal with that, whether it's 1 drug, 2 drugs, or even 3 drugs. And that we have a lot of safe and effective therapies today. And if adherence is a problem, I think the less frequent injections with something like inclisiran may be one of the keys. In fact, Dr. Bhatt, I don't know if you saw this, but there was a nice abstract at AHA in November showing that inclisiran, compared even to monoclonals, had slightly higher adherence rates. So I think the hypothesis that this drug will improve adherence is at least upheld by some preliminary data. It would be nice to see further data on that coming out. So we'll be happy to take questions. I'll let Dr. Bhatt moderate those, and I'll try to answer some, and we can go back and forth. So Deepak,
Great.
Back to you.
Yep. Yeah, so we've only got a couple of minutes, so we'll keep our answers brief. Maybe I'll start with Dr. Wright. What's the difference between ApoA and ApoB?
ApoA, HDL, ApoB, LDL. ApoB causes plaque.
Yep, that's terrific. This is a great question. What's about the possibility of adverse reactions when starting multiple new medications at the same visit? As we were talking a bit about combo therapy, but is that a downside to it?
Of course it is. But fortunately, the adverse reactions are infrequent, 4 to 5%. And I caution patients about that. What do you do? What do you think, Deepak?
I think the risks of adverse effects are lower with low-dose statin therapy or lower-dose statin therapy. So I think when started with, ezetimibe, I think there's, for example, less likelihood of an adverse reaction than just starting with, say, atorvastatin 80 or rosuvastatin 40 right out of the gate. So actually, I think as with blood pressure medicine, the lower dosing of 2 medicines versus a super high dosing of 1 typically has less side effects, not more. Here's another good question. With the increasing popularity of dietary supplements for lipid lowering, particularly red yeast rice, what are your thoughts about efficacy and safety with them?
I don't think we know about safety. Red yeast rice is like the equivalent of 5 to 10 milligrams of lovastatin or 0.5 milligram of atorvastatin or 1. So it's going to work a little bit. And some patients need to have we all have autonomy concerns, right? We all want to feel like we're in control. And unfortunately, medical illness has stripped that control away from all of us. And I see most people who want to try natural things as wanting to feel like they're in control of their health. And I give them permission to do that. But at least we have a discussion that if this doesn't do it enough, then let's come back again in 2 months and reassess and then maybe talk about something stronger. I would say with natural supplements, I saw a case recently with an LDL that was 190 because he was having a supplement and it had a lot of medium chain triglycerides. And once the supplement went away, his LDL went from 190 to 100. And so I would say some supplements are very harmful in terms of raising lipids, so be careful.
Yeah, I agree 100%. I think we talked about evidence-based therapy and prescription medicines. That's the way to go. If people really want to do things naturally, then I'd say that's what diet and exercise is all about. I favor a diet that is high in fresh fruit and vegetables and whole grains, relatively lower absent in things like red meat, regular daily exercise. So that's the natural way to do it. Supplements aren't a natural way. So sometimes patients, I think, fixate on that. But I would say if you want truly natural, stick with diet and exercise. Maybe this could be the last question. Given the landscape of dyslipidemia management, there's some new therapies. Can you elaborate on some promising and innovative therapies? I'll just mention one and then turn it over to Dr. Wright and let him close. I guess what I found most interesting, AHA, in terms of things down the pike, was gene editing in humans to try to treat familial hypercholesterolemia, with the potential promise of that approach even for folks, at high risk with high LDL without specifically familial hypercholesterolemia. As I mentioned already, need a lot more human data, longer term data, but so far the data, I think, scientifically very, very exciting.
Yeah, thank you. I would agree. I think there's some risk with that, with an off-target coding error rate of up to 20% with Casper-Chris. I think it's Casper-Chris 8 or 9. I forget the number, but something just to think about. I saw one question pop in. Someone said, what about a high HDL? My view is that a high HDL is not protective, and that always look for secondary causes. Frequently, it's excess alcohol intake in those patients. Okay. Well, I think that's all the time we have, unfortunately. Again, thank you for joining us. It's been a pleasure to be with you tonight. I appreciate the chance to work with Deepak Bhatt. And Deepak, hope you have a wonderful evening as well.
You as well. Real pleasure doing this with you. I hope the audience enjoyed it.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.